Are you able to hear me? Because oh, there you are. Hi. So I'm David Weinstein. I'm the medical lead at Passage Bio for the GM1 project. And I came to Passage last year after 30 years in the academic world where I focused on rare disease and gene therapy. I am old fashioned. And since we have now begun our human trial, we began in March, I feel it's important to have a little space between the companies and the families. And so I am honored to be able to introduce Janine Jarnes, who needs no introduction to this community. Janine has been involved with GM1 work and work in the whole gangliosidosis field for many years. She has one of the natural history protocols that was aforementioned during some of the other talks. And we are very honored to have her as our clinical lead for the trial, the Imagine-1 trial, which she will now describe. So thank you, Janine, for presenting this.
Thank you for the introduction, Dr. Weinstein. And I will be talking about a new therapy in clinical trials called PBGM01. This is a Passage Bio product, and it is a gene therapy. And we've already discussed GM1 gangliosidosis, but I just want to review that this condition is caused by a defect in a gene called GLB1. And the defect results in a deficiency of an enzyme, beta-galactosidase. And this leads to many serious symptoms and a life-threatening illness in these patients. This deficiency of the enzyme, if addressed properly, we could theorize that that would cure the disease. And that's the idea behind these gene therapies, is to try to address this enzyme deficiency. So with this new gene therapy, PBGM01, a GLB1 gene is produced in the lab, a healthy gene, and it is encapsulated or packaged in something called the AAV virus. And as Sam Parker talked a little about this too, this is not a virus that can cause an infection. The package system is derived from an AAV virus, but it will not cause any harm to the patient in terms of infection. And then this gene therapy, or this gene that is in this package, is injected into the patient. And Sam Parker from Lysogene talked about a similar or the same administration route. As you can see on this picture, with the needle going into an area in the base of the brain, the injection will be into an intracisterna magna area. And it is hoped that it will circulate in fluid that is in the spinal cord and the intracisterna magna and the ventricles in the brain, and come in contact with brain cells that desperately need this enzyme, and that this packaged gene will be taken up into the brain cells, and then that the enzyme, the correct form of the enzyme, will start to be made by the cells in the brain. And also that some of this enzyme will leave the brain, it is hoped, to travel throughout the rest of the patient's body and address other areas that are also affected by GM1 gangliosidosis, including the liver and the spleen and the heart. So this slide here is showing a little more on this route of administration, or the way the drug is being injected into the patients in this trial. And it's called a cisterna magna injection. And as I said on the previous slide, this injection it's a one-time dose. This gene therapy typically, as we know it today, is a one-time dose. And that's one of the big ways it differs from other therapies that are on the market. But it's injected in this space between the base of the brain and the spinal cord, and then circulates through the fluid in there, which is cerebral spinal fluid, and is able to come directly in contact with cells in the brain. And again, this is very important, that this aspect is very important in other words, the coming in contact with the cells of the brain, because that is the area that is most severely affected in these patients, the brain. And I'd like to talk about a little further about why this route was chosen. There's a number of different routes over the last decade or two by which gene therapies have been administered to patients for many different conditions. A common route is intravenous, and that's that first column on this slide. IV stands for intravenous, and many therapies are given that way. One of the difficulties with that for treating a disease that is most predominantly in the brain, is that it's difficult often to get the therapy that's given intravenously to get it to go into the brain. In other words, to cross what we call the blood-brain barrier and to get into the brain where it needs to go. Sometimes you can overcome that challenge by giving very, very high doses of whatever therapy you're administering. And this has been demonstrated in a number of studies. One of the drawbacks of giving a very high dose is it may create toxicities elsewhere, because maybe we don't need that high of a dose in other areas of the body. Lumbar injections, the second column, those have been tried for a number of gene therapies. It's given into the spinal column with hopes that it will travel sort of up into the brain area through that cerebral spinal fluid. Another route that has been used in a few trials is something called intraventricular. Now, this injection is going into that cerebral spinal fluid that I mentioned earlier. But to get there, the needle has to go through the brain itself, through the parenchyma into that area. There is a potential risk here because you're actually putting a needle through brain tissue. And do we really want to do that? Well, we might have to if that's the only way to treat the disease. But it's the hope that this cisterna magna route will be able to avoid any toxicity that you would get from putting the needle through the actual brain tissue itself. And we're still able to get the drug into that cerebral spinal fluid, and importantly, that area where the fluid is really coming in contact with brain tissue. Then this package containing the gene, the vector that it's packaged in, we call it a vector, the AAV, the adeno-associated virus, the vector package helps get this gene therapy up into the cells. It helps it travel into the cells, and then the gene is released there. And then again, as I mentioned, we'd hope that the cells would use that gene to make the enzyme these patients are missing. And the animal models in which this has been studied prior to putting it into humans have demonstrated that it is in fact able to do that in the animals. So there's great hope that we'll see similar results in humans. So what population will receive these first few doses of PBGM01? This trial will be starting out in patients who have infantile GM1 gangliosidosis and late infantile GM1 gangliosidosis. Infantile is also called type 1 GM1, and the late infantile is oftentimes called type 2A GM1. They are both more rapidly progressing. They progress more rapidly than other forms of GM1 gangliosidosis, such as juvenile GM1 gangliosidosis and an adult form where patients really start having symptoms later in life, usually in early adulthood. So this infantile form and the late infantile are more rapidly progressing. These will be the two types of GM1 that will first be able to receive the PBGM01 therapy. Now, these two types of GM1 are distinguished by their early onset. In the infantile form, we know the patients have definite symptoms that are noticeable by the parents and their family doctors by the age of 4 to 6 months. In patients with the late infantile form, the symptoms may not become really obvious until around 10 months of age, one year of age. So how is this clinical trial designed? Well, this is a little bit a busy slide, but if you look at the six circles on the right, you will see they are all named cohort 1, cohort 2. These are 6 different groups of patients for which the trial is planned to be administered in. And the very first, they'll be in the same sequential numbers as is shown here. So we see cohort 1. This will be the very first group of patients to receive the gene therapy. And this will be in the late infantile group of patients first. There will only be 2 patients in this first cohort. Between a dose, when one patient receives a dose, there will be a minimum of 60 days before the next patient can receive the dose, and this will occur throughout the trial. The 60-day wait period will allow the researchers to make sure that everything's okay, that there's no safety concerns, and that everything is going well with the patient, so that if everything looks good, they will progress to the next patient and let the next patient receive a dose. There are 2 doses that are being studied in the trial at this time. There is a lower dose and a higher dose. If need be, during the trial, adjustments will be made to that. Overall, this trial is trying to find out, is this new gene therapy safe? Is it well tolerated by the patients? And eventually to find out, is it working? Is it efficacious? Is it actually changing the condition of the patient, improving their clinical status, helping to slow down or stop the progression of GM1, or even bring improvements in the patient's development so that they are no longer progressing in their GM1. So eventually the trial will be looking at efficacy. Initially, in these first few cohorts listed here, the major concern is this safe and is it well tolerated? Now, the therapy in the animal models was well tolerated by the animals. So we hope to see the same in the humans. And at the end of this phase 1, phase 2 trial, it is hoped that the best dose for the patients will be identified. What is the best dose for them? So Sam Parker talked about travel fatigue, and this slide is basically addressing the same thing. How much time will the families need to invest if they have a child in this trial? And there are a number of visits that will occur over a period of 5 years. Initially, the patients will, if they want to enter the trial, if the parents want their child to enter the trial, they will spend about 2 weeks at the clinical trial location, having the patient screened for the trial. Numerous evaluations will be done. If the child is a good candidate for the gene therapy and they're offered a chance to enter the trial, then they will receive a dose of the 1 dose of the gene therapy. Then they will be monitored in the hospital for a couple days, for 48 hours. This is just extra safety precaution to make sure there's nothing concerning going on, and to just monitor closely to make sure that nothing is missed. The families will also be asked to stay near the clinical trial site for 30 days after the patient receives their dose. This is again to be able to monitor the patient very closely during the 30 days after that dose, to do some blood work, but basically just to make sure there's nothing concerning that or anything, or that we're not missing anything on the data that might be important. The sponsor for this trial will cover the travel costs and will make it as easy as possible for the families to do this in terms of the financial costs that would be involved for this more intensive sort of travel and staying near the clinical trial site. This trial will last, it's planned right now to last for 5 years, following the patients closely for the first 2 years, and then following them also long-term over a total of 5 years. And there's a total of 12 visits to the clinical trial site here listed. As you can see, year 1, there's 7 visits. So year 1 is going to be a busy year. And year 2, there's 2 visits, and then 1 visit on year 3, 4, and 5. General anesthesia will be required in this trial. So this means the children will be put under full anesthesia. And it's important for the parents to know this. There will be a total of 7 times that are scheduled for the patient to be put under general anesthesia. At screening, the day that the dose is given, and then 5 additional times during the clinical trial period. During general anesthesia, a number of procedures will take place, including brain MRIs, nerve conduction studies, hearing tests, vision tests, lumbar puncture. Some of these evaluations can cause pain and discomfort to the patient if the patient was under not under anesthesia, or even under just a conscious sedation. It might be more uncomfortable. By doing these procedures under general anesthesia, it ensures the patient will be the most comfortable and will not feel any effects of these procedures if there was discomfort involved. This here is, again, discussing this slide here is discussing this 2-week period in which the patients are being screened to see if they can qualify for the study. And again, as mentioned before, there's a number of procedures, another number of evaluations, echocardiograms, abdominal ultrasound, MRI, nerve conduction studies, some blood work. Following the administration of the drug, so the patient gets their one-time dose injection, there will be at the following visits over this 5-year period, there will continue to be evaluations to look for changes that occur, improvements or not, just to see what happens after giving this dose of gene therapy. And again, this will include a physical exam, neurological exam, more hearing tests, more vision tests, more MRIs of the brain. The health of the heart will be followed, and that will be through ECG and echocardiogram. EEGs will look for seizure onset or changes in seizure status in the patients. There will be some spinal x-rays. Patients with GM1 gangliosidosis, it's not uncommon for them to have some spinal deformities such as scoliosis or kyphosis. So that will be monitored during this trial. There will also be some neuropsychiatric testing, or we might call it neurodevelopmental testing. This will be done by a neuropsychologist and maybe a few members of the neuropsychologist team. And this will be done during the visits multiple times. And they will be looking for changes in cognitive skills, changes in, and that can include language, how the child communicates. You know, a lot of these children aren't able to say any words, but they might communicate through some vocal sounds, and that will be evaluated to see if that is maintaining or improving. Social and emotional interactions of the patient, and as well as motor skills, fine and gross motor skills. Quality of life will be measured during these sessions. There'll be numerous tools, but some of the common tools are listed here, the Vineland 2 and the Bailey 3. In addition to all the evaluations done at the clinical trial site, the parents of the child will be asked to try to capture some of the skills of the patients to help us monitor for changes in their skills. Some of these skills when they come to the clinical trial site, for whatever reason, the child doesn't demonstrate whether or not they can do it during the time that they're there, but at home they may be demonstrating it on a regular basis, and the parents can capture this by video, and then the investigators can monitor for changes in these skills and abilities over time. This may include just how the patient's able to make eye contact, whether the patient is able to see a toy and reach out for it, or show interest in it and focus on it, whether or not the patient is able to have enough strength to hold their head up and turn their head. For patients with the late infantile form, oftentimes these patients learn how to walk. They learn how to crawl and to surf furniture and how to walk, and then they start losing those abilities. If they're still able to do these abilities, or if they improve as a result of the gene therapy, we hope to be able to capture this on video, and it will greatly enhance what we learn from this trial. What are the risks of gene therapy? Well, there was a question about that after Sam Parker's talk also. Known risks that we've seen in kind of universally with gene therapies are some liver inflammation. This can be monitored by doing some simple blood tests, and it can also be oftentimes addressed and completely controlled by some interventions or measures we can do if we see this occurring. Damage to the nerves that connect the spinal cord to the rest of the body. We have seen this happen with some AAV9 therapies and AAV9 variant therapies. So this is something that we know can happen. Thus far in a number of the animal studies, it appears that, especially like in the non-human primates, that it doesn't appear to be progressive, and but this will be monitored closely during this trial, as it should in any trial using AAV9 or a variant of AAV9. Platelets may become lower. This will be monitored by simple blood tests. So other risks of any clinical trial are if a patient's put under general anesthesia. So these risks will be discussed with the parents. prior to entering into the trial. And if the parents consent and say, yeah, I still would like my child to try this, that's their decision. Also, as you see in the red labeling here, this is a first in human study. So no one can predict with any investigational agent what will happen. They aren't totally confident in what types of side effects might occur or what types of benefits might occur. And this is the reason we have clinical trials, so that we can explore these things. This is also the reason why the patient or the caregiver is allowed the total freedom of choice as to whether or not they want to try the new drug, and they consent to this process. If a family is interested in learning more about this new gene therapy by Passage Bio, PBGM01, they can log onto this website, www.pbgm01.com, and they can indicate that they want more information. Now, importantly, this website does not relay the family's interest to Passage Bio, so Passage Bio will not know if a family reaches out. The reason for this is we want the families to feel like they have complete confidentiality when they show their initial interest. The clinical trial sites will also not know if families are logging into this website asking for information. And that way that just gives the families a little more freedom of choice and confidentiality in the initial query into this new therapy. But if the family decides they want to pursue it and have their child evaluated for the clinical trial, or if the family decides, I'm not sure I want the child in the trial, but can I please have a visit at the investigational site and learn more about it? Then they would fill out this page on the website, and their information would be forwarded on. They would be matched with a clinical trial site that will be the best, probably the most convenient for them in terms of proximity, and they will be given further instructions on how to proceed. The sites where this clinical trial are happening is numerous sites throughout the world. We have 4 in the USA, 1 in Brazil, 3 in Canada, 1 in Turkey, 1 in the UK. And let's, to go back to this topic about who is included in this phase 1, phase 2 trial. This initial phase 1, phase 2 trial, as I already mentioned, will be in patients that have the infantile form of the disease and the late infantile form. Now, there are many patients with GM1 gangliosidosis who have the juvenile form of the disease. There are also some patients that have a later onset, later in life, sometimes in early adulthood. And all these patients are experiencing the catastrophic effects of this disease. So Passage Bio wants to communicate to all the families that they recognize that this is a catastrophic disease, regardless of what type the patient has. And they hope to be able to expand their therapy options into the juvenile and the adult forms of the disease, and be able to really reach out and provide new therapy options for all the different types of GM1 gangliosidosis. We call those phenotypes, all the different phenotypes: the infantile, the late infantile, the juvenile, and the adult. And Passage Bio will be working collaboratively to discuss opportunities that they hope can apply to all patients with GM1. But initially, to get through this first phase 1-2 trial, we hope to learn a lot, and we hope to be able to know where to go, what the next steps are to go from there, so that hopefully this therapy will be able to benefit many patients with GM1 gangliosidosis. And I'm speaking on behalf of Passage Bio. I work at the University of Minnesota, but they wanted me to express that they would like to thank the Cure GM1 Foundation and NTSAD for their support and efforts to help the GM1 community, and to thank the families for their trust and encouragement. And that concludes my presentation.
Fantastic. Thank you, Dr. Jarnes. That was really clear and wonderful presentation.